Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. In my previous video, I talked about the clinical presentation, causes, complication and investigations of acute liver failure. Please click the link in the description below if you're interested. In this video, I'd like to continue discussing the severity assessment, prognosis and management of acute liver failure. How can we evaluate the severity and prognosis of acute liver failure? Basically, we can assess the patient's age, the cause of the acute liver failure, the onset of encephalopathy, and blood tests such as PT-INR, pH, lactate, serum bilirubin, and creatinine concentration. The factors to predict prognosis of acute liver failure depends on whether it is paracetamol or non-paracetamol etiologies. In general, the prognosis is worse in patients who are younger than 10 years or older than 40 years, who have indeterminate causes of liver failure, and who develops encephalopathy more than 7 days after jaundice, INR more than 3.5, persistent acidosis and high lactate, and increasing serum bilirubin and creatinine concentrations. Recent studies show high phosphate level on ICU admission in patients with paracetamol overdose could be related to poor prognosis as well. In patients with acute on chronic liver failure, we can use Chi-Pu score, the Model End-Stage Liver Disease MELT score, or modified SOFA score, that is CLIF SOFA score, CLIF AD and CLIF C score. Now, I would like to talk about how to manage patients with acute liver failure who are admitted to intensive care unit. Timely recognition of acute liver failure is of the utmost importance for patients who will be considered for urgent liver transplantation. The decision to proceed to transplantation is made by a multidisciplinary team depending on etiology, clinical presentation, and prognostic criteria. The management of stable chronic liver disease is rarely the responsibility of intensivists, except in specialist centers, where planned interventions or surgical procedures are to be performed in such patients. Essentially, there are 4 main areas in acute liver failure management: close monitoring of multi-organ failure, resuscitation and organ support if there is any organ failure to minimize complications, treat the cause, and early referral and transfer to specialist center for consideration of liver transplant if there is any potential for rapid deterioration in patients with acute liver failure. While monitoring such patients, please bear in mind that trends are often more important than absolute values. We need to particularly assess their neurology, like cognition, flapping tremors, tendon reflexes, clonus, and motor and cerebellar dysfunction, GCS and pupils, basically to determine if encephalopathy is getting worse, if there is any features of increased ICP. We should also monitor basic parameters such as SpO2, respiratory rate, heart rate, blood pressure, ECG, urine output, fluid balance, blood glucose, and temperature to see if there is any other major organ impairment. Intra-abdominal pressure monitoring may be useful in patients with tense ascites. In addition to clinical and physiological variables, assessment of liver function with regular full blood count, electrolytes, liver and renal function tests, ammonia, and coagulation profiles, including fibrinogen, should be monitored. Arterial blood gases should also be done frequently to watch pH and lactate. One of the major reasons to admit critically ill patients with acute liver failure is to support vital organs. All patients with severe encephalopathy with low GCS and loss of airway reflexes should be intubated and mechanically ventilated even if their gas exchange is normal. Intravascular volume assessment could be quite tricky in such patients. In acute liver failure, patients are not normally sodium and fluid overloaded, unlike those with underlying chronic liver failure, especially if they're having ascites. If patients are fluid depleted, we can use albumin or balanced crystalloid like Hartmann's solution for fluid resuscitation. In hypotensive patients with chronic liver disease, we need to be very cautious with fluid resuscitation, and vasopressors should be considered early as well as hydrocortisone. Hypoglycemia is a common complication, and when it is treated with dextrose infusion, we need to ensure the sodium level is not falling. Besides, fever, seizures, cough, and agitation should be controlled well as part of neuroprotective measures in patients who are at risk of cerebral edema and increased ICP. I've discussed neuroprotective measures and how to manage increased ICP in my previous video of traumatic brain injury, so if you're interested, I've put the link in the description below. Electrolyte imbalance should be treated with appropriate replacement, and sodium level should be aimed above 145 mmol per liter. Consider hemofiltration in patients with severe metabolic acidosis and uremic encephalopathy. Fluid balance should be kept neutral. We should start nutrition in liver failure patients as soon as possible. Dietitians should be involved to calculate the optimal protein intake suitable for the patients. Proton pump inhibitors are important to prevent GI bleeding. If there is any active GI bleed, high-dose PPI and also talipressin should be considered. Arrange urgent endoscopy to identify bleeding point and provide treatment simultaneously if feasible. Hematologists should be consulted and transfuse accordingly to correct coagulopathy. Balloon tamponade such as Sandstake and Blakemore tube or Minnesota tube should be used to control refractory variceal bleeding. If there is rebleeding despite these treatments or portal hypertension with portal pressure more than 20 mm mercury, transjugular intrahepatic portal systemic shunt stent should be considered early to improve survival in patients with Child-Pugh score B or C and refractory bleeding at endoscopy. Besides, risk of rebleeding can also be reduced with non-selective beta blockers in patients with cirrhosis. Hence, it should be restarted once stabilized. I would like to highlight here, if there is no active bleeding, we do not treat coagulopathy because coagulation profile is used to assess potential for liver transplant. We can liaise with surgeons if the cause of liver failure is trauma or pregnancy related. Infections tend to complicate patients with liver failure. Thus, we need to treat any infections with antibiotics and, if needed, add antifungal after discussing with microbiologists. Even if there is no evidence of infection, antibiotic prophylaxis should be considered as routine in all patients with advanced encephalopathy. On intensive care unit, we will insert arterial lines for continuous blood pressure and ABG monitoring, central venous catheters for infusions, and if required, fast-cath catheters for potential renal replacement therapy. While ongoing organ supports, underlying cause, if known, must be treated at the same time. Unfortunately, specific treatment options for acute liver failure are quite handful. In the UK, we use tox-based guidelines to deal with drug overdose, and in paracetamol toxicity, we can start N-acetylcysteine. For other causes of acute liver failure, as intensivists, we need to involve other specialists for specific management, for example, immunosuppressive therapies in autoimmune hepatitis, antivirals in viral hepatitis, and anticoagulation in venous thrombosis. From our intensive care perspective, severely ill patients with acute liver failure are best treated in a specialist unit with the capacity to provide liver transplantation. As I mentioned earlier, we need to monitor patients closely for prognostic factors to recognize rapid deterioration, engage with specialist transplant center early, and follow their advice. Patients should be safely transferred to regional transplant centers for assessment before criteria for liver transplantation are met. In patients with paracetamol toxicity, if there is any evidence of metabolic acidosis with pH less than 7.3, bicarb less than 20, lactate more than 2, INR more than 3, or if the INR trend is worsening with creatinine more than 200 micromole per liter, if there is any evidence of encephalopathy, or mean arterial pressure less than 60 mm mercury despite volume resuscitation, then we need to discuss with liver specialists for early transfer. For other causes of acute liver failure, we should consider discussing with specialist centers if they have jaundice with bilirubin more than 150, coagulopathy with INR more than 2, encephalopathy, renal failure, hyponatremia, ascites, and metabolic acidosis with lactate more than 2 following initial resuscitation. Patients with chronic liver failure may be suitable for transfer if they are appropriate candidates for specialist endoscopic management, TIPS, or transjugular liver biopsy. Liver trauma patients should be managed in hospitals with interventional radiology facility for bleeding control and the capacity to perform ERCP. The decision to proceed with liver transplantation depends upon the probability of spontaneous hepatic recovery. The aim is to differentiate patients who are likely to benefit from liver transplantation from those who are potential to recover spontaneously in order to avoid lifelong immunosuppression in patients who have recovered without liver transplantation. It is essential to identify the contraindications of transplantation, such as severe cardiopulmonary disease, extrahepatic malignancy, and intentional overdose or substance abuse. Here in the UK, we use King's College criteria for liver transplant in patients with paracetamol-induced acute liver failure, which include arterial pH less than 7.3 or all of the 3 factors such as prothrombin time more than 100 seconds, creatinine more than 300 micromole per liter, grade 3 or 4 encephalopathy. For other causes of acute liver failure, the factors to predict poor prognosis, which I have already discussed at the beginning of this video, would be indications for liver transplantation. In patients with acute liver failure who have poor prognostic factors, chance of survival with medical therapy alone is less than 10%. The major cause of death in patients with acute severe liver failure without any stigmata of chronic liver disease is cerebral edema. GI bleeding, sepsis, and multi-organ failure are common, and these are signs of decompensation and new onset of acute on chronic liver failure, as well as frequent causes of death in those awaiting liver transplant and in those who do not fulfill transplant criteria. Patients undergoing urgent liver transplantation for acute liver failure have a worse 1-year survival rate than those undergoing elective transplantation. Patients with only encephalopathy prior to liver transplant is likely to have a better chance of 3-month survival than those who require organ supports for multi-organ failure. Most of the 12-month mortality in acute liver failure patients occur in the first 3 months after transplantation, unlike those with chronic liver disease whose comorbidities may be ongoing over the subsequent years. Patients admitted with a variceal bleed normally have a better prognosis than those admitted with multiple organ failure and sepsis. Aggressive organ support is indicated in all patients with acute liver failure, no matter if transplantation is planned. In patients with decompensated chronic liver disease, as intensivists, we should focus on the acute condition like sepsis, bleeding, rather than the etiology of the liver disease. In such patients, admission to ICU for organ support and observation of patient's trajectory for 48 hours will be appropriate, especially if it is their first time presentation. The families of all critically ill patients with liver disease require support and understanding. For patients with acute liver failure, the onset of the disease could be very sudden, and the patient may be completely normal one day and require mechanical ventilation and multiple organ support on the next day. Relatives may have problems understanding the reason for confusion and rapid deterioration of their patients. The risk of encephalopathy and cerebral edema should be explained early and fully. They normally get angry since the diagnosis or recognition of severity of disease was not made earlier. They should be explained that many patients with liver disease are asymptomatic until their episode of decompensation. Another frequent concern is the risk of infectious process or hereditary conditions, and further investigations and management of other family members may be required. The role of transplantation also needs to be explained. We need to clarify that liver transplantation is only offered to those with poor prognostic criteria in acute liver failure. Moreover, we need to make it clear that not all patients who do not fulfill transplant criteria will survive. In the setting of chronic liver disease and established multiple organ failure, regarding the decision on whether to offer liver transplant or not, family members may find it difficult to understand, especially if the patient is transferred to a specialist center for assessment. We will require to explain that it is unlikely to offer liver transplantation unless the patient improved significantly in the first place. Patients going through transplantation process for acute liver failure and their families will require quite a lot of psychological support as well, because they do not usually have memory of being ill, unlike patients with chronic liver disease. That's it for me in this video. Hope this video is useful for you. If it is, please share with your friends and colleagues. I'll see you in the next video. Take care.